At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I have the great privilege of being your host for GLI Live. This month, we get to recognize both National Nutrition Month and National Reading Month. So some of my favorite things together. And so I have with me two of my other favorite things, multidisciplinary partnerships between dietitians and hepatologists. And so here to represent their disciplines and give us some fantastic information, I have Kristen Kirkpatrick, who is co-author of Skinny Liver and Regenerative Health, two books that we will learn more about. She is also a dietitian in the Department of Wellness and Preventive Medicine at Cleveland Clinic, a little place you may or may not have heard of. And I have with us as well, I mean, hug a gastroenterologist always is like everyday theme for me. Find one and hug them, give them some appreciation. I have with us Dr. Abraham Hunena, who is the other co-author of Skinny Liver and Regenerative Health. We got not just one, but two books that talk about the importance of liver health. So all of us in this community who have felt, abandoned and ignored, wait no longer, we have champions for you. And so with that, I'll say hello, because otherwise I just go on for 30 minutes talking about how wonderful you are. Kristen, why don't I let you start and tell us about who you are and how you got connected to liver health.
Sure. So yeah, thanks so much for having me. It's such an honor and a privilege to be here and to be with your audience. I love this tagline of starting with a patient, because that's where I started. I started with one patient coming into my office and saying, my doctor tells me that I'm a little bit overweight, I'm a little insulin resistant, like literally using the word a little. Mm-hmm. So very non-scientific, right? When we were talking about the biometrics, and I probably have a fatty liver, there's no treatment, so here I am. And it was the here I am moment where I really became interested, so much more interested in this organ, in this disease, in what the public thinks the liver does and what the liver actually does. And I really wanted to kind of spread the word, if you will, and really bring this into the limelight. There's so many dietitians that will write books about very specific diets or weight loss, or, sometimes even things that are so specific, they're a little bit wacky. But I wanted to focus on something that we haven't seen coming out of a dietitian, and definitely not a dietitian hepatologist pair. So It started with a patient for me as well. Someone walking in saying, hey, there's no guide here. There's no medication. What's next?
Absolutely. And so, Abraham, what say you? You have, I don't want to, you have a lot of explaining for some of your fellow gastroenterologists and hepatologists who have let a lot of people walk out of their offices just saying they just have a little this or that, when liver diseases can be very serious. And so why did you want to really step up and conquer this aspect of the problem?
Yeah, thank you very much for having us. It's an honor to be with you and your audience. I'm fascinated by the liver. It's the only organ that regenerates. Really, no other internal organ in the body regenerates except the liver. And I'm kind of overwhelmed by the new epidemic of fatty liver disease. And I call it epidemic because it affected so many people. 25% of the world has fatty liver disease. 1 out of 4 people have fatty liver disease. It's a very common problem. It's reversible if you diagnose the condition and intervene early on. And that's technically where I got interested in fatty liver disease. Kristen and I, we used to work at the Cleveland Clinic, and that's how we connected many, many years ago. And I realized quite honestly that this is a disease cannot be treated by a gastroenterologist alone. You got to work with your dietitian friend, and like a wise man once said, "Let the food be your medicine." This is a disease where the right medicine is food. So that's how we got connected, and we worked on the skinny liver, and more recently on the regenerative health.
Right. I so appreciate the book, and I had I'm never right on these. Skinny liver. I had skinny liver first in my bookshelf, and it was such an important addition because I thought I would have to rely on Dr. Abraham Verghese and Cutting for Stone to have any reference to the liver that was credible and sourced in my on my bookshelf. And so you wrote this book first, so the same year that we started our NASH Council. And it gave a lot of really useful information because, like you, the most common thing I hear from patients coming to us is, what should I eat? What should I do? Even if my doctor said, "Oh, and I'm going to be on this plan," but I still need to know what to do in the course of my day. And then you made such a wonderful and needed statement about science evolves. And I think that was one of the problems during COVID, that we hadn't appreciated that science updates and evolves. It's not that something was wrong in the past necessarily. It's that science evolves. And as we know more, we can do different things. As Maya Angelou says, when we know better, we do better. And so tell us how your thinking across the two books evolved, because I think people should, having read them both, I think people should read them both, buy them both, and read them both, or go to your local library or get an audiobook. But anyways, I like hardcover, so I should. People should buy them both. But what was your thought process in the evolution between your two books? First, maybe from Kristen, and then Abraham.
Sure. So the first book was really just a starting guide. It was to introduce people to the liver. Obviously, all three of us know a lot about the liver. We're passionate about the liver, but the general population is not. So that was the real goal, is to say, hey, there's this amazing organ we have. We never think about it. And we are killing it, slowly killing it. And here's the evolution of how we're doing that. So it was really more high level. We wanted to bring that awareness to the general public. The second book is much more specific in terms of dietary recommendations. It does update the science. Dr. Henane can really talk about this further, but I think the big updates of science is really even looking at the change in nomenclature, which we know indicates that this disease, non-alcoholic fatty liver disease, is a disease that is completely mediated by metabolic indicators. And so we talked about that a little bit in the first book, but now we know so much more about our metabolic health and how it affects the liver. And that was really why we said we have to get a new book out there to update the science.
And I love that you've both updated the science and the recipes. so there's knowledge and really actionable things that you can run down to the kitchen to do. Abraham, your thought on the evolution of this?
Yeah, no, I agree. I mean, the name, as Kristen said, the name of fatty liver disease has changed recently. We call it now metabolic associated fatty liver disease, because we realize this is a disease associated with metabolic syndrome. And so that tells you that there have been a lot of changes in our knowledge about this disease in the past 10 years or so. We learned, the name fatty liver, as the name implies, is fat in the liver. And people think, we actually thought some years ago, many, many years ago, that if you eat fat, you will get fatty liver. Well, the science over the last several years evolved, and we learned now that if you eat carbs, you will get fatty liver. We learned that this is a disease associated with carbs. And that's technically where we also learned that one size doesn't fit all. There are 4 metabolic types, and depending on your metabolic types, here's the low or medium carbs diet that fits you the most. we also learned about some supplements that could be beneficial to the liver. We can talk about them later on, but coffee, for example, over the last 10 years, more and more research shows that black coffee is excellent detox for the liver. You want to detox your liver? Don't spend your money on supplements and stuff like that. Don't go too far. Black coffee does it. Among other things that we put in the notebook.
That is one of the black coffee is, and the knowledge about how it can improve liver health and even reverse fibrosis is one of the only reasons I get invited back to things. Because as you can imagine, when people find out that I lead a liver group, they're sort of hiding their wine glasses at the reception and become very uncomfortable and awkward. And so my sentence usually is, I'm like, do you drink coffee in the morning? And they, happily say yes. I'm like, well, then you're doing something good for your liver health. And so I'm back on the list. And green tea as well has some wonderful agents that also advance liver health. And I think giving people, it's such a relief to find that there are things that people have in their own homes. They're not like, it doesn't need to be, exotic, expensive, hard to access things that have real credible, evidence behind them because people are inundated with so much misinformation. We often say what little they know about the liver health is wrong. They know nothing. What little they know is wrong. Other than that, it's just fine. And so your books are so helpful to be able to give people, credible and accessible advice on really what to do as we evolve the other parts of the system. And they match very nicely the profiles that you've talked about in terms of the types of people, of sort of profiles of characteristics in your book match very nicely with what we're looking at in terms of how people can be matched to treatment plans once they are linked to care and not just told that they have a little fatty liver, but that they should be followed, by a cardiologist and endocrinologist and, primary care at least should be paying attention, and we'll have some, but maybe a hepatologist as well. But not everybody is at end-stage liver disease. There were a majority of people are at these very early stages, and you've, really described and characterized them very nicely. And so maybe, Ibrahim, if you want to go into the profiles a little bit about, how people can see themselves and, place themselves in the book and really know, which types of actions to pursue.
Before we go to the profile, we part of the reason we went there, we dislike BMI, body mass index. It's such a inaccurate way to characterize conditions and among other things. So we decided to go with the waist circumference. The waist circumference is the way to go. For many reasons. One, because it's more accurate than BMI, and two, it reflects the central obesity, if you will, or the central fat, which is the most dangerous fat. When fat sits in the center, if you will, in the center of the abdomen, that's going to go straight to the liver through the big vein called the portal vein, and that's going to cause fatty liver and a problem. So the 4 metabolic types takes into account, number one, the waist circumference, and then, low or high, etc. And then number 2, the presence or absence of metabolic syndrome. And there are metabolic syndromes. There are 5 criteria of the syndrome. If you meet 2 out of 5, in addition to increased waist circumference, then you have the metabolic type, if you will, that is associated with fatty liver. The 5 metabolic traits, if you will, that define metabolic syndromes are the presence or absence of type 2 diabetes, if sugar in the bloodstream is high, number 1. Number 2, increased blood pressure. Number 3, increased triglyceride. Number 4, low HDL, the good cholesterol. You want that to be high. When it's low, it's a problem. And so those 4, in addition to the 5, which is the increased waist circumference, define metabolic syndrome. So the metabolic syndrome and the waist circumference define those types, the 4 metabolic types. We have the lean, and the metabolically unhealthy. We have the lean and metabolically healthy. We have non-lean and metabolically healthy, and we have lean and metabolically unhealthy. And then we go on to describe the best diet that fits each one of those metabolic types.
I think that is so easy for people to understand. Often we are caught up in the complexity of the nomenclature change. I'm like, because putting things in Latin always makes things easier to understand. And as we are still evolving, the types of non-invasive diagnostics to use as we get beyond the biopsy, surely, and the order or sequence in which, or combinations in which we use those different non-invasive diagnostics. The tape measure, taking your waist circumference is sort of the ultimate scalable tool that most people have around the house. And as a global organization, always asking my team for something that works in Seattle as well as Senegal. We're talking with our teams in India and Vietnam. I was like, well, take a waist circumference. We don't have to, wait for fancy imaging. Fancy imaging is very nice. I've had a lot of it and certainly benefited from it. But waist circumference is something that can be used throughout the world in communities to give everyone a starting place. And then the risk factors you talk about are the reasons why, we invited the American Heart Association and the Endocrine Society and ACE and the Association of Black Cardiologists and all of these, cardiovascular and endocrine groups, in the hopes that this is a opportunity that we can grow, that no matter sort of what door you enter into, we can treat all the controllable factors of your metabolic health. So if you come in through a cardiologist, that hopefully your diabetes can be identified and your fatty liver disease can be identified and treated. If you come through a hepatology door, then the other factors can be dealt with as well. And if we do this right, and we're trying, and these books are helping, that we can end up with populations of people who are metabolically healthier at the end of the day, in all of these aspects, liver, renal, and heart. And so that, to me, is the exciting opportunity. And liver was the missing piece in this to this date. And so this has been exciting. I want to ask you maybe the reaction. And has this gotten traction? Do people believe this? Is this the sort of coming together of all of these different specialties that we have hoped to see? So just the reaction of the books and the have you seen changes in greater acceptance by endocrinologists and cardiologists about regenerative health and including the liver?
Yeah, I think it provides the guide. And regenerative health provides even a more detailed guide. Things we really wanted to be cognizant of and sensitive to is there's so much discussion right now about diet culture and restriction, deprivation. So I think off the bat, whenever I'm talking to my patient and I say, hey, I want you to consider a moderate to low carb approach, in their head, they're like, oh, that's deprivation. I can't have carbs anymore. But hopefully what we've done in the book is really kind of show the opposite end of this, that it's not about not having carbs. It's about taking a general Mediterranean diet approach, because when you look at data, there's really no better diet than the Mediterranean diet for me. So we started with that as our base, and then kind of trickling down to here are some ways we can modify carbohydrates in each of these metabolic profiles. Never are we going into a keto diet or something like that. So, and we also talk about the fact that you can go in and out of our plans, and really about restriction. It's just trying to open your eyes to better blood sugar management. So I think from the reaction, once people get that, it's really looking at, all right, this sounds something that's doable. I don't any longer feel like, oh my gosh, I can't have this anymore, and this is a bad food and this is a good food.
Right.
That was really important to us. And I think Dr. Hananay's point, we did want to take away this stigma that if you have a high BMI, then automatically you're not healthy. That's just not the case. So I think that's really been well embraced as well. Some people might have a high BMI that may not be reflective of poor health. So really, it's a call to action to truly dive deeper into our health, encourage people not just to accept BMI as the standard, but ask your doctor, run some labs. Let me see what my blood sugar is. Let me see what my lipid panel is.
Right.
It's so important to the overall health of this organ.
Ibrahim, one of the things that I've been wondering about, and I'm going to carry this into DDW and a lot of different discussions that I've had with my own gastroenterologist, I, for a very long time, have had a scale that gives me my lean body mass and my and my hydration. So as a person with Crohn's disease and a liver transplant, my hydration is, both of those are, important to me. And so I often have conversations with my gastroenterologist and I realize, oh, I'm operating off of more data than you have. Certainly with my Oura Ring and my Apple Watch, I know I have operating a lot more data. But just the simple, getting away from BMI and operating from how much lean body mass does this patient have? How well hydrated, is this person? Is there, technology support to, raise the standards in gastroenterology to help gastroenterologists practice better, just ways that we can support them to give the type of care that we want to receive and have these types of conversations with their patients that we'd like them to have?
Yeah, no, great question. And I kind of, I agree with you. I think there is certainly a room for improvement, among gastroenterologists, not to mention among people outside, GI, specifically primary care physician, because that's where you're going to capture the vast majority of patients with fatty liver disease when they go to see their primary or annual physical. And to your point, you don't look just at the BMI or increased weight, etc. Because there are some people who are lean and they still get fatty liver disease, for variety of reasons. Some people are genetically susceptible to develop fatty liver disease. Some people, Crohn's disease, for example, I'm sure you know this, they are susceptible to get fatty liver disease. And actually, they are susceptible to get more severe forms of fatty liver disease. They tend to accelerate at a higher degree. Some of the medication we use for Crohn's disease tend to cause liver disease as well. So yeah, there is certainly a room for improvement. I'm thankful for the American Diabetes Association came out a couple of years ago, and they said everybody with type 2 diabetes need to be screened for fatty liver, even if they have no signs or symptoms of liver disease. The American Association for Study of Liver Disease, the ASLD guidelines, they came up with new guidelines last year, 2023, and they said, yeah, if you do have metabolic syndrome, you might want to consider screening for fatty liver disease. So I think, there is definitely increased awareness in the medical society, and I think in general population, to get this disease under control. 1 in 4 people get fatty liver disease. I mean, we got to do better.
Absolutely. The sound today, it's echoing. I think that's because everybody needs to hear this, even the people in the back row. I think the sound is for everybody in the back row. I think you were certainly right that primary care doctors, because of the number of people involved and the number of people who are at early and seemingly silent stages of this disease, are being, will need to be managed, are found in primary care practices, if you look, and will need to be managed there. And I know that primary care doctors feel rather overwhelmed by having to add sort of another thing to many things that we are asking them to do. I think of this more just as sort of closing the loop on the basic things that they're doing in terms of keeping their patients metabolically healthy. Are there ways that, since you are so good with words, are there ways that we should be communicating with primary cares and with advanced nurse practitioners, advanced practice providers, and sort of widening the tent of people who will need to help us help patients with any type of fatty liver, or anybody who wants to pay attention to their liver health? How have you started sort of recruiting more people on board?
Yeah, we've done some education in our community in Minnesota, and quite honestly, it starts with screening. Think about it. Think about fatty liver disease and screen for fatty liver disease. If you see someone coming in for routine annual physical and they have metabolic syndrome, they have type 2 diabetes, high blood pressure, high cholesterol, sleep apnea, obstructive sleep apnea, polycystic ovarian syndrome, family history of fatty liver disease. They have risk factors. And even if they have no signs or symptoms of liver disease, even if their liver enzymes are normal, if you will, you got to screen them for fatty liver disease. Screening is pretty easy. It's actually not much extra work. You go and see your annual, your primary care for annual physical. You're probably going to get some blood test. So please make sure that the liver tests are included if you do have risk factor for fatty liver disease. And then, if you do have risk factors, it's not unreasonable to get a picture of your liver with ultrasound or fibroscan or some kind of, imaging technology to find out if you have fat in your liver or not. That would be a good start. And then if fatty liver is present, the next step probably to refer to a specialist, gastroenterologist, to determine how much damage you have in your liver from fatty liver. And then we'll take it from there. But long story short, screening. If you do have patients with risk factors of fatty liver disease,
and I would add screening your whole family. If somebody has have a diagnosis of fatty liver disease, then we've had success in bringing whole families in for screening and finding, and then they need to go to the dietitian because the whole family then needs to learn how to eat differently and move differently and just maybe create a different family culture that's more liver health promoting. And so first of all, is that sort of family screening, are we on the right track with that? And then Kristen, how do you help a whole family?
Yeah, so I think when we think about let me just back up and say this. This is the first time we didn't really cover children in our first book. We did cover a family plan, and we did address children in our second book because the data, if you look at the statistics, shows that children as early as 8 years old are developing this disease. And the one advantage, let's say, that kids have over someone who may be diagnosed much later in life is time. And that's not an advantage for the liver. A child will live a very long amount of years. And if no lifestyle change occurs, then there's a lot more opportunity for this disease to progress to some really scary stages. Less likely to happen if someone is diagnosed much later in life. So when we think about kids, and this happens all the time, when someone emails me and says, oh my gosh, my 10-year-old is an awful eater. Do you think you could meet with my 10-year-old? And my approach is always, I can meet with you. Because even at 10, the parents have the greatest influence on the dietary patterns of the child. They are dictating what comes into the house. They are showing by example what they're actually consuming. So the family is so important in creating change. If we look at the statistics of waist circumference in mom and dad, if they are higher, it's much more likely that the child will have a higher waist circumference as well. So even if a parent comes to me and says, oh, I'm good, my diet's pretty good, I guarantee you there's things we can change to improve not just the child, but the parents. So doing it together creates an accountability type of matrix. So, hey, we're doing it as a group. We're not just saying, hey, you 8-year-old, you have to make changes. We're not going to do anything because we're all perfect here. So we really did want to approach that and create a family plan for individuals that say our entire family needs to focus on better liver health. And here's how we're going to do it.
I think that's wonderful. Abraham, do you have entire families that you're treating, or how do family dynamics play into your work?
Oh, indeed. One example comes to my mind. Probably a couple of years ago, I had a patient who came to me because, he said, I want to get screened for fatty liver disease, which is kind of, oh, wow, wasn't even referred. Well, yes, because you took care of my mom, who also had fatty liver disease, and unfortunately she didn't do well. It was late stage disease and led to bad outcome. Before she passed, she told her son, my new patient, to make sure, to get yourself screened for fatty liver disease. And she asked him to promise her to take care of himself and get that fixed. So yeah, that's just one example. I always encourage, patient with fatty liver disease. It's like, hey, you better tell your family member, particularly if they have risk factor for fatty liver disease, to get them screened. Because to the point earlier, Donna, this is a disease. You find it early, you reverse it, the rest is history. You live happily ever after. You don't want to wait until too late in the game, because it can lead to bad outcome that may not be reversible when it's too late. Cirrhosis, the need for liver transplant, liver cancer, etc. We don't want to wait that long.
As somebody who has experienced that end-stage liver disease and been, waiting in the ICU for a life-saving liver transplant, I wholeheartedly endorse finding and helping people much earlier. And that's why we're having this conversation during Obesity Care Week, and doing it in combination with our friends in the diabetes and obesity and cardiovascular community, and making sure that all of these conditions are treated with the urgency that they need to be treated, because it is fatty liver disease, not just a little, fatty liver is the right term. And so I'm so grateful to have both of you here, and so grateful to have both of you, available anytime that we want to read them and have them on our shelves and in our ears. To understand what we can do today in our own lives to improve our liver health. So thank you.
Thank you.
Thank you very much, Dana.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.